Welcome to Health Professional Radio. I'm your host, Neil Howard. This morning, this segment, we're going to be talking with Dr. Eric Klein, chairman of the Glickman Urological and Kidney Institute and a staff member of the Taussig Cancer Institute at Cleveland Clinic. And he's joining us to talk about prostate cancer research released at the American Urological Association 2020 meeting, talking about Oncotype DX Genomic Prostate Score, or GPS testing, and African-American men with clinically localized prostate cancer. Welcome to Health Professional Radio, Dr. Klein.
Happy to be here.
Well, I did mention your role there at the Cancer Institute. Give us a bit of your background.
Yeah, I'm a urologic oncologist specializing in prostate cancer. I've been practicing here in Cleveland for a little over 30 years, and my clinical interests have been in the clinical management of all stages of prostate cancer.
Now, we hear a lot about late-stage cancer. We hear a lot about early detection. Are we talking advanced prostate cancer or early detected prostate cancer, or somewhere in the middle when we're talking about this type of testing?
Yeah, this test was developed to address challenges in predicting tumor aggressiveness based on biopsy in the context in the last 15 years of recognizing that PSA screening detects a lot of low-grade cancer that doesn't need to be treated. And our current clinical tools predicting who has a cancer that needs treatment and who doesn't are good but not perfect. And so the idea here was to take this gene expression technology, which was new and hot 15 years ago when this was started to be developed, and see if we could develop a test where we could measure these 17 genes on a biopsy to help determine if someone is a candidate for active surveillance, where their tumor is simply monitored and not treated unless it becomes more aggressive, or whether the patient has a cancer that needs treatment. And that's what it's intended for and what it's been used for.
When most people hear cancer, they're not considering a certain cancer or any cancer that can go untreated. When a cancer, as you say, can go untreated, is this something that, you know, as you say, it's only going to, if it gets more aggressive, then we'll take a look at it. But if it just sits for 10 years and doesn't do anything, I mean, I didn't think cancer did that.
Yes, so some cancers do. So prostate cancer has varying degrees of aggressiveness, which are primarily measured by the grade, what's named after a pathologist called Gleason. So there are 5 Gleason grade groups. In grade group 1 or Gleason score 6 cancers, we know in the vast majority of patients are never destined to hurt a patient, or if they are, they grow slowly and can be monitored. And so about 15 years ago, various groups, notably in Toronto and in Baltimore, developed a routine called active surveillance, where patients who are initially diagnosed with these low-grade cancers and have other favorable features are not treated. And we have long-term data now, 15-year data now, that shows if you select the correct patients, that it's actually safe to do that. And the vast majority of avoid treatment-related side effects, and the vast majority of men who do get a little more aggressive cancer are cured. And so that's the preferred management strategy now, according to clinical practice and all the guidelines, is active surveillance. But you're right, some patients balk at the idea of watching a cancer, and that's where this test comes in. Cancer aggressiveness currently is assessed on a biopsy that a pathologist looks at under a microscope, but that doesn't capture the entire biologic potential of the tumor. You have to look at the molecular changes that are present and happen before the cancer looks more aggressive. And that's exactly what this test does. It takes a little bit of tumor. You only need 1 millimeter of tumor to be able to get a result from this test. And it can confirm that, in fact, the pathologist sees only low-grade cancer, and that's really what it is, and the patient's safe for surveillance. Or it can suggest that there is more aggressive cancer present, which could dictate a harder look, a rebiopsy or an MRI to see if there's higher grade cancer that was missed, or in some instances go right to treatment.
So how prevalent is this early stage prostate cancer? I mean, is it so prevalent that this test is widely needed?
Yes. So, it's very prevalent. So, although I have to say becoming less prevalent. So when PSA, the blood screening test that we use for prostate cancer, first came along in the late 80s, right when I started my career, we really believed that we needed to treat every cancer that we found. And back then, that was probably correct. What happened over the years is that men starting at age 50 typically got repeated PSA testing over many years. We started doing biopsies for slight rises in PSA, and we started finding a lot of these low-grade cancers, which are actually very prevalent, and we'd really rather not know about. I mean, many men live their entire life, die of something, heart disease or stroke or old age or that sort of thing, and actually had prostate cancer that was never detected. PSA allowed us to detect these low-grade cancers. So we recognized after about 10 years of PSA testing that a lot of the cancers that PSA was finding were these low-grade cancers that didn't need treatment. And so it was a very prevalent problem. It's becoming less prevalent because we're more careful about who we recommend biopsy for. So now we require a repeat PSA to confirm that an initial PSA was actually elevated. There are some second-generation based PSA tests that are more accurate in figuring out whether or not someone should be biopsied because they may have a high-grade cancer. We have imaging studies now, MRI, and that sort of thing.
Is the prevalence of this early-stage detectable cancer, is it prevalent across the board in subjects, or are there some segments of the population that it's more prevalent in?
Well, it's a challenging question. It's been observed for many decades now that African American men are at highest risk and seem to have the highest death rate due to prostate cancer of any racially or ethnically defined group in the world. And there's been a lot of discussion about why that is. Some of it, at least in the past, and probably still in the present, relates to access to care. Some of it may relate to attitudes about seeking care. Some of it may relate to diet. And some of it may be biology. There are some thoughts that the biology of prostate cancer in African Americans and other groups is different. That latter question or that latter issue has come into question recently because if you look at outcomes after treatment in Caucasians and African American men, it turns out that African American men are cured at the same rate as everybody else is when they are diagnosed and treated. And interestingly, there's even a study that shows that for men with metastatic cancer who get a certain drug called Taxotere, that African American men seem to even respond better to that. So it's this idea that the African American men have more aggressive cancer is probably not correct. It probably has to do with other things.
Now, this Oncotype DX genomic prostate score, let's talk about this test, the availability and the accuracy of it.
Yeah, so, it's available commercially. It's covered by Medicare for certain specific indications, and many private insurance cover it also. The out-of-pocket expense for when it's not covered is actually quite reasonable. So it is widely available. It has to be ordered by a physician, typically the urologist who does the biopsy, and then the pathologist pulls the slides and sends the tumor out to the company, and the result comes back in 10 or 14 days, something like that. Its accuracy, it's not perfect like any other test, but it adds clinical value in distinguishing who has a cancer that can be watched and who has a cancer that can be treated. We have some unpublished data now from the original 500 or so patients that we used to develop this test. And at 20 years, a simple GPS score can predict your likelihood of getting metastatic disease or of dying of prostate cancer. And so higher scores, the emerging data suggests a score at 30 or above is really something to worry about. And those patients may not be the ideal candidates for active surveillance, particularly if they're young and have a long life expectancy. Lower scores are suggestive that maybe that patient is a good candidate for surveillance. The whole point of this study was to, compare how the test performs in Caucasians and African Americans in the background of this prior debate about whether or not there are biologic differences between that. And what the study showed was that the test is equally valid in both.
Well, where can our listeners get some more information online about this GPS test?
There's lots of published studies for physicians. I would suggest they go to PubMed and search for 17-gene genomic assay or 17-gene score. That's usually the title in the article. There is information on consumer-facing high-quality websites like WebMD and UpToDate. There is information in guidelines published by the National Comprehensive Cancer Center. And the company's website also has some very general overview of what the test looks like and how it can be ordered.
Eric, I thank you so much for coming on this morning and speaking with us here on Health Professional Radio.
A pleasure. Thank you.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Eric Klein, chairman of the Glickman Urological and Kidney Institute and staff member in the Taussig Cancer Institute at Cleveland Clinic. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.